and I'm also currently the chair of NANSIG, which is the Neurology and Neurosurgery Interest Group. This is a international student and junior doctor-led organisation that spans 15 countries. So yeah, just thought I'd give that a little plug. And welcome to Neurological Emergencies Part 2. Let's just get the slides going. Okay, so a lot of questions. There's going to be a lot of polls, a lot of interactivity, and a lot of questions. But just to gauge where people are at in their stage of training or their journey, I'd just like to ask first, what year group are you in, if that's okay. So I think there might be a poll coming up. I'm not sure. Well, yeah. So if you can just tell me which one you're in, and then I can gauge how the teaching is going to go. And how we'll approach it. And of course, any questions throughout, just post them in the chat and I'll answer them as they come in. Oh yes, and I'm sorry, the other's not been added. I think that's because I changed it last minute. I apologize. But yeah, if okay, so that should be good. Just gonna end that. Okay, so most people are between, the middle clinical ranges and the final year of their respective degree in training. That's great. So that tells me I can go into a lot of depth. You have a good clinical understanding foundation already. Here, I'm just here to kind of intellectually challenge you and hopefully go through some key essentials. That's what we'll do today. What we're going to cover in part 2 is specifically content that's going to be related to medical school finals, if you have your exams coming up, or essentially what you need to know for your medical final exams, or as a proficient junior doctor, wherever you are based. The cases we're going to cover today are going to be about reduced Glasgow Coma Scale, or GCS, / consciousness level, meningitis and encephalitis, giant cell arteritis, headaches, and Cauda Equina syndrome. But we're going to go through them as interactive cases, followed by a nice summary. So here's how we're going to navigate our journey today through the talk. We're going to start off by going through some cases, and then we're going to engage you with some questions. I'm going to provide you with the answers. I'm going to equip you with some one-slide summaries to remember each condition succinctly and with only the pertinent information. And then hopefully we'll have information ready for your medical finals. And with that being said, let's go. So case 1 is called the Old Lady, and it's not a reference to Juventus, the football club. Here's the case history. Jenny, a 82-year-old female, attends her GP, which is her family medicine or family doctor, or family physician, for her first appointment in 10 years. She states that she doesn't like to be a bother and she doesn't like to make too much trouble, which is why she hasn't came in. She's been troubled with back pain for the last day or so, and it came on quite suddenly. She also noticed at the same time that she had leg weakness of her right side, and she actually can't get out of her chair at the moment. Upon further questioning, she admits that she's had a few accidents in terms of her bladder and her bowels during the same period. And on examination, she has reduced power bilaterally in both legs, and she can't feel pinprick sensation around her perianal area. My first question is, what do people think are some possible differentials for this case? And if possible, could you just type them into the chat and we'll go from there.
So the chat is exploding with people saying Cauda Equina syndrome and cord compression.
Yeah, perfect. So so people saying Cauda Equina and cord compression. Yeah, these are all things that I'd be thinking of without a doubt. So often, I know it's a bit counterintuitive, but the med schools, they like you to come up with more than one potential diagnosis for things rather than the straight answer. I know we know the answer, but we just need to think of, other things that it potentially could be, even if it's not ideal. So yeah, definitely things like a compressive myelopathy, like a, even things like a stroke, it would be much less likely. But yeah, mainly cord compression and Cauda Equina syndrome. Okay. So what happens next? Well, you send the patients to the emergency department, and the same history is taken by another doctor. You phone the neurosurgeon on call, who recommends that you carry out a urgent full body MRI, particularly of the lumbosacral spine. The patient, she's got no medical history or no surgical history, and she doesn't take any medications. And the MRI shows this on the right-hand side there. It's on the next slide, so I'm just going to skip this one. So question 2 is, what does this MRI scan show? Obviously, it's a sagittal section of the lumbosacral spine. And take your time with this. So, because I still find these very tricky to interpret, even at okay, so that's pretty stable. Oh, we've got a couple more. That's great, thank you, Will. So most people, around 60%, have got the correct answer, and so people have said that it's answer number C, or letter C, and that's correct. 40% thought it was core compression L4, L5, and I can see why, but I'll just take you through why the answer is C. So essentially, you've got a sagittal T2 MRI. It's T2 because the white milky fluid there is your CSF, sorry, and that is appears white on a T2 weighted MR. It's in the sagittal view, and we can see the vertebrae. Quite clearly, we can see a striking abnormality in the sense that the spinal cord and surrounding area is compressed. There's that little deficit there where it kind of tapers off. So we know that there's some core compression of some sort. Now, what we need to delineate is the exact level. And really how we can do this is by appreciating the difference between sacral and lumbar vertebrae. The sacral vertebrae generally tend to curve posteriorly or angle posteriorly. And so you can see on the image, if you find the third from bottom of the vertebrae, you can see that that is quite uniform. It's joined with the other two, but there's a little bit of a gap and change in angle between itself and the one above. That is the start of the sacral vertebrae, so that is S1, and the one above it is the L5 vertebrae. So as you can see, also in between the L5 and the S1 vertebrae, the intervertebral disc, which you can actually see quite clearly in most of the other vertebrae connecting the two, it's not as visible there, and that's because it's herniated actually backwards and compressed the spinal cord, and thus, as it is between the levels of L5 and S1, because S1 is below and L5 is above, the core compression is at the L5 and S1 level. Now, what symptoms that'll cause, which spinal nerves it affects specifically, that's a bit more complicated, but what we can tell is that's the level of compression. So question 3 is, assume that you're in a UK hospital for for the purpose of these questions, by the way. You've seen this scan. So the next question is, what is the next best management plan for this patient, given the fact that they've got those symptoms and they have that scan result? Just a few more answers coming in there. Okay, that's pretty stable. And most people, again, about 3/4 have got that one right again. This patient clearly has, classic Cauda Equina syndrome, given the symptoms and the MRI scan, and therefore the only treatment for this patient that's in their best interest is urgent surgical decompression. As far as the oncology team would go, they've got compression from a disc and not from a cancerous tumor. I wouldn't repeat an MRI because this one is pretty conclusive that we have. Managed conservatively wouldn't be appropriate in this patient, and the only other answer that people selected was giving urgent dexamethasone and having the on-call neurosurgeon see them tomorrow. It's come to light recently that Cauda Equina is a surgical emergency and therefore needs to be operated on when discovered as soon as possible. So even though potentially giving dexamethasone is sometimes warranted, waiting until the next day for the neurosurgeon to actually come around and speak to them is not good, because it would adversely affect their prognosis. So here is a one-slide summary of everything you need to know about Cauda Equina syndrome. It's a constellation of symptoms that result from compression of the Cauda Equina, which is the horse's tail, which is essentially the nerve fibers below the spinal cord. As illustrated in this classic case, the most common cause is lumbar disc herniation, which just happens acutely, and it's linked to a combination of degenerative disc disease, sometimes trauma, but you can also get sometimes you can also get traumatic causes, so spinal cord injury below the Cauda Equina that impinges the fibers, and rarely tumors as well. Let's just get back to the slide there. So I was trying to look at the chat. I think someone had asked a question there. What if the patient wasn't fit for surgery? It's a really tricky one, because at the end of as a potential consequence of not giving the patient surgery, what you can be left with is the patient having permanent disturbed bladder and bowel function, which people commonly report, even if they're healthy, that it's very deleterious on their quality of life. Most patients will, even if they're not exactly fit for surgery, still go and have a decompression. But it depends on the surgeon's management. If they're not appropriate, if they're not fit for surgery, say if there's an absolute contraindication as to why they shouldn't, and there's no way to optimize that, you would just consider conservatively managing the patient. Say if they're a nursing home resident or something like that, you would manage them conservatively. Some surgeons give dexamethasone, but I don't believe it's in the NICE guidelines at the moment in the UK. But that's pretty much all you could do. The key features everyone knows, and they're exhibited in this case: back pain, bowel and bladder dysfunction is one of the crucial symptoms. And you can also get leg weakness and sensory dysfunction as a result. On examination, it's a classical pattern you'll see is the reduced perianal sensation, which is called saddle anesthesia. Once again, this is classic of the condition. It's an enormous source of medical litigation, both in the UK and overseas. I believe in the United Kingdom, the average cost of missing Cauda Equina to a GP or to any clinician, the average cost is around £200,000, which patients will win from hospitals to pay for their funding if they don't get discovered. The guidance you need to know is that the NICE guidelines in the UK recommend that all patients with suspected Cauda Equina syndrome have a MRI of the lumbosacral spine within 24 hours of symptom onset, and that is absolutely essential in these patients. Even if you're not sure, it's better to exclude Cauda Equina than to risk it. And the one main treatment for Cauda Equina is urgent surgical decompression. So I've just had a couple of questions there. One is Cauda Equina a sudden or gradual onset? Really, it depends on the pathology. So most patients with Cauda Equina, as it's caused by lumbar disc herniation, most patients may have sciatica for many months. Those kind of symptoms of numbness and tingling in the leg, weakness, but they won't have bladder or bowel function affected. But then something will happen, and within a few days, a disc will properly herniate and cause symptoms to develop rather rapidly once the cauda equina is compressed in itself. But there are some exceptions where patients can present gradually, but chances are it's going to be a sudden onset within the next few days or so. Someone has asked about, I hope that answers the question. It said no audio. Will, can you hear me okay?
Yeah, I think it's working for the rest of us. Karen, maybe if you choose, if you check the volume on your computer, and if that fails, try disconnecting and reconnecting. That normally helps people.
Yeah, so it's good that we can continue. Saddle anesthesia, meaning that the lesion is likely extramedullary, right? Well, by default, it's pressing on the spinal. It's pressing on the spinal cord, so and it's coming from the disc. So by default, it would be extramedullary, yes. But there are some exceptions like intramedullary spinal tumors, but I'm not getting into that at the moment. As I've said, to summarize, the treatment really is urgent neurosurgical decompression as soon as possible. We're now thinking, I do some research into Cauda Equina syndrome at the moment, and there's a lot of evidence to say that the faster you can decompress, the better the patient outcome. So that's actually not the full story. One key question that I'd like to ask you is, so I've chatted a lot about Cauda Equina syndrome, but what symptom have I perhaps not mentioned or forgot to mention so far that is absolutely imperative, is absolutely critical to ask patients with suspected Cauda Equina syndrome about in your clinical examinations, also known as OSCEs, and in real life as a doctor? So if you
Will said erectile dysfunction.
So I think sexual dysfunction is the correct answer. Very well done. That's probably one of the biggest telltale symptoms of Cauda Equina syndrome that is just not asked about. Most people won't ask patients about it, and it's really one of the most sensitive and specific signs you can actually have. So please don't forget to ask your patients if they've had sexual dysfunction at all, along with their onset of symptoms, because if they have, it points more towards Cauda Equina syndrome than anything else. Okay, case number 2. A vague presentation, but how do you make sense of it? And I've just got some images there of things that to me make absolutely no sense. Okay, so here's the case history. Your patient's name is Paul. He is a 65-year-old male. He was found collapsed and unresponsive by his son today. He last saw Paul yesterday and just went to go check on him today. So it's been 24 hours since he was last seen by anyone. He has a past medical history of alcohol excess, and his son tells you that he had a brain tumor removed 3 years ago, but he can't tell you anything else. He's brought to the accident and emergency department, and you're the first doctor to see him. You take one look at him from the edge of the bed, and you can see that he is very drowsy and is unresponsive to you trying to get his attention. First question is, in that situation, what is the next best thing that you should do for your patient? So what is the next step you should take as a junior doctor? Okay, so that looks like most people have answered. Already slowing down. And once again, really good, guys. 3/4 of you have got that one exactly spot on. The correct answer is A, is just carry out an A to E assessment, consisting of assessing the patient's airway, their breathing, their circulation, their potential disabilities, and exposure. Out of all the other options, always start simple. You haven't reviewed the patient yet. You've just taken one look at them. So we don't even know what's wrong with them. And although it's tempting to go for the CT head first, it could be something completely different. I know they've got a history of a tumor, but they've also got a history of alcohol excess. So it's important to kind of, just perform a thorough assessment first, and that will help give you a clue as to what might be going on. Question 2 is you conduct an ATE assessment as planned, and you know that the patient's airway is fine. They're maintaining the airway. Breathing rate is fine. It's all normal. However, when you get to the disability section, you note that there is no visible limb movement on the left-hand side. You also find that his eyes are completely closed, but they do open when you squeeze his trapezius muscle, evoking a painful stimulus. He's also groaning, but he isn't formulating any words. So he's kind of moaning, not really saying anything clearly. And then when you apply another pain stimulus, you note that he pulls his limb away from the stimulus. So you grab his right nail and he pulls his arm away from it. So the question is, what is Paul's Glasgow Coma Scale, also known as GCS? So have a think about this one, because it takes some time to add up all the different components. And if you're not familiar with it, that's okay, because we're going to go through it in just a sec. So it seems like a lot of people might not be too familiar with the Glasgow Coma Scale, which makes sense. It is employed worldwide, but probably it's very commonly employed in kind of countries like the USA and the UK. But we will go through it, so not a problem. Okay, so we can stop it there. So most people have actually got this one right, but it's a lot more obvious than the last few questions. 35% of people got this one right. The correct answer is C. This patient has a Glasgow Coma Scale of 8, and I'll explain why. So I've got it on the next slide, but just my interpretation of this patient is their eyes. So their eyes are open, but their eyes open in response to pain. This corresponds with a score of 2 points. The patient is groaning but not formulating words. I perceive this to be incomprehensible sounds, which gives you a score of 2 on the Coma Scale. And as someone's pointed out really well in the comments, the person has, when you go for the motor function, when you apply the pain to see what their motor function's like, the patient withdraws away from the stimulus. And when someone withdraws from a stimulus, that's 4 points. So that's 2 plus 2 plus 4, which is 8. So someone's asking, what is the difference between localizing pain and withdrawing to pain? And someone's answered that really well in the comment below. Essentially, if you cause a painful stimulus on one side of the body, say with a trapezium muscle squeeze or something like that, and the patient, say if they're unconscious, but they still say their hand comes up to try and take your hand away from the painful stimulus. So if you squeeze the traps and they bring their hand up to try and remove your hand away from the place where you're causing the pain, that's called localizing to pain, because they move towards where the stimulus is. And in comparison, withdrawing from the pain is the opposite, where if you squeeze it, the patient, without knowing it, rather than move towards the pain, their arm will actually move away from the pain, which doesn't make sense, and it tells you that they're not all right. But anyway, the breakdown is on the next slide. Oh no, it's not. There's another question, and then there's a break. There's the explanation. My next question is, at this stage, what are some possible causes or reasons for Paul's reduced consciousness level? based on, the history, based on the examination findings, based on pretty much your overall impression. What possible things could be going on? So yeah, just
Okay, so we've got an intracranial bleed, stroke, intoxication, alcohol intoxication, STH, sepsis, stroke or bleeding, hemorrhage, hypoglycemia. Nice range of things here. Tumor someone's got, epileptic seizure, CVA. I think that's all we've got so far.
That's perfect. Well, that's brilliant, guys. Thank you very much for answering that. And I think this goes on. This really is the point I was trying to summarize. Is we've actually got quite a lot of responses there that are very different to each other, and that's exactly what I'm getting at. This could be a myriad of possible things we don't know yet, but coming up with those ideas and having a way of doing that is really great. So all those answers were completely appropriate, given the patient's clinical history. So you speak to a senior because you're thinking about all these diagnoses and you're not really too sure what's going on. Your senior advises that you carry out a CT head scan as an emergency, and you do this, and it shows this right here. So my question is, so now that you know the history, you know the examination findings, you know what the CT scan shows because it's there, what is the next step in managing this patient? What would you do next? And you can assume that you're a junior doctor at this point. If you're more skilled, that's okay. Assume you're at that stage, that relevant to where you're at in your training. But just for relevance, or just for the purposes of this clinical scenario. Okay, so we've hit about 70% response. That's great. Really well answered question. 60% of people in attendance got this one exactly right. The correct answer, at least from my perspective, would be letter B, which is commence dexamethasone and to call the neurosurgeons quite quickly. The reason why is because clearly there's a very large space-occupying lesion on the right-hand side of this patient's scan, and it's also causing, if you go to the midline and you draw a line downwards where the falx is, you note that there's significant distortion. There's no symmetry left to the brain at all as a result of this mass. So this huge space-occupying lesion is causing mass effect and distorting the brain completely. There's also evidence of impending hydrocephalus on this scan. Yeah, so it's a good question. I think someone had asked, I was thinking someone would, so there's two questions, sorry. I'll just answer the last one, but then I'll answer the second last one. Someone has asked, would you want to rule out a abscess before starting DEX, or does the CT rule out an abscess? It's a great question. So, and I was hoping someone would ask it. This scan, it does show a big space-occupying lesion, and without a doubt, a differential possible cause of a space-occupying lesion is a cerebral abscess. However, there's substantial evidence, not just in the clinical history, but also on the scan, to suggest that this is definitely a brain tumor and not a cerebral abscess. For instance, in the history, the patient is not febrile. They don't have a fever. They are not systemically unwell. As I recall, the 8E observations were all normal in this patient. The only finding was big weakness. So the absence of a fever, systemically unwell, the absence of seizures, it tells you that it's less likely to be an infective cause. In addition, the patient doesn't have a history of risk factors that would make him predisposed to a cerebral abscess. That doesn't categorically rule it out, but it just helps you paint your picture towards something else. And the fact that he's had a brain tumor previously, it tells you that that is much more likely. Now looking at the scan, there's a few subtle details that make you indicate that it's probably a brain tumor. So if you look closely, the rim around the tumor, you can see there's this white rim around the tumor. It doesn't extend all the way around. So it's not a true ring enhancing lesion. Once again, that suggests it's much more likely to be a tumor, as ring enhancing, it has to be fully ring enhancing, as most abscesses are. And secondly, if you look to the right of the tumor or the mass, you can see that there's kind of dark spaces around the brain, and that is massive edema. So generally speaking, abscesses don't produce as much edema as tumors, but it suggests that there's significant edema or fluid around this mass. And that to me, once again, says it's probably a brain tumor. And in keeping with the patient's clinical history of having one, it means you really need to just give them dexamethasone. It's much more likely to be a tumor, and call the neurosurgeons. I think someone's asked me if I'd be worried about the patient would lose their airway with a GCS of 8. And the answer is yes, I would. But the reason why the answer isn't C, which is attempt to intubate with a nasopharyngeal airway, is because the firstly is 8 and not less than 8. And secondly, because you tend to intubate when the GCS is less than 8. Although I agree that if you are on 8, you need to be thinking about it. But I certainly wouldn't attempt to intubate the patient using a nasopharyngeal airway. I'd rather, as a junior doctor in that position, start the medication and call the neurosurgeons for urgent advice as to what to do next. So it's just about kind of the person you are in that situation. And I think the last question is, yes, Gayatri, that's exactly right. There is occipital horn compression. There is occipital horn of lateral ventricle compression as seen by the tumor, and it's causing quite big hydrocephalus, and there's raised intracranial pressure as a result of that. So once again, giving dexamethasone to reduce the intracranial pressure acutely will be very helpful in this patient. And it's something you as a junior doctor or a junior clinician could do. So here is the reduced GCS / consciousness level 1-slide summary. For those that don't know about it, the Glasgow Coma Scale, or GCS, is a frequently used quick assessment to assess someone's consciousness level. It's broken down into 3 points. EVM, so eyes, verbal, and motor. Eyes, it's up to 4 points, verbal up to 5, and motor up to 6 points, for a maximum score of 15. Now, the 1 point you need to remember is that if a patient's GCS is less than 8, you intubate. And what that means is you get anesthetic intervention for your patient, because if it's less than 8, as someone said in the chat, you don't maintain your airway, which means that you're actually at risk of course, dying, because you don't have the consciousness level to maintain your own airway. There's the scale. I'm happy to send the slides to people a bit after this talk as well. And I also thought that for people that were thinking of causes of why this patient had a reduced consciousness level, there could be so many causes, as you all listed. And one of the ways to come up with and think about every possible diagnosis it could be is to use the surgical sieve, which I'm sure most people are aware. But for those that aren't, it's just a way of using a mnemonic to come up with as many different causes of the patient's clinical presentation as possible. And I use one called vitamin, which stands for vascular causes of pathology, infectious causes, traumatic causes, autoimmune causes, metabolic, iatrogenic, and finally neoplastic. And as you can see, if you use those terms and you can use that mnemonic, you can come up with about 20 different diagnoses that it is that you all came up with in the chat. So I'd recommend using something like that in your approach to coming up with potential diagnoses for patients. Case 3, we've only got 2 cases to go. Case 3 is called the unwell student. The history, you see Nadia, who's a 21-year-old female, and she's a university student. She was brought into the accident and emergency department by her friends. She's been unwell for 3 days, and she's not been eating, and she has a severe headache. Her friends have described that all they've done is seen her in a room with the lights off. And on examination, you note that she is barely rousable, and she has a temperature of 38.2 degrees Celsius, which is elevated. Question 1, nice and simple, is based on the information that you have, what is the most likely diagnosis for this patient? I hope this one's relatively straightforward. Okay, that's great. Most people seem to have answered there. Okay. So yeah, most people have got that one right. It's pretty classical. Someone's got fever and a headache and photophobia. So the top of anyone's list should be meningitis. The next question is, if this patient as well had evidence of altered behavior and consciousness level, as well as having 2 seizures, what would be the other most likely diagnosis apart from meningitis? Okay, so I think most people have answered there. Exactly, really well done again. The 83% of people have got that one right. The answer is encephalitis. Encephalitis, I just remember it is meningitis plus, so pretty much meningitis features plus altered consciousness level, altered behavior, and you can also get seizures due to the organism that causes it. But I'll get onto that. So what happens next is, as part of the patient's management, you carry out a lumbar puncture for suspected meningitis, and the results are shown below. So as you can see, according to the lumbar puncture results, the opening pressure is raised, the appearance is turbid, there's a high protein, there's a high white cell count, lymphocytes are normal, the glucose is low, and the gram stain is positive for gram-negative cocci. So given that information, the next question is, which of the following organisms is the cause of Nadia's meningitis? And I think someone has asked a question. They've asked, do you assume a patient has encephalitis if they have a history of epilepsy? See, that's a really, really tricky one. I think you'd have to, in that instance, you'd have to keep both of them in mind because it could represent meningitis occurring on top of their epilepsy, or it could represent encephalitis just by itself. So I think you couldn't assume anything in that situation. In the meantime, the poll is finished and 90% of people have got this right. And the correct answer, as everyone has said, is it's bacterial. Most likely, it's going to be Neisseria meningitidis, which is a gram-negative cocci, which was identified on the staining, the gram staining. The other features that are indicative of meningitis on a lumbar puncture are raised opening. Firstly meningitis. You can tell based on all the parameters, but indications that it's bacterial are the raised opening pressure, the turbid or pus-like appearance of the fluid, raised protein, low glucose, and of course that gram stain. So here is a one-sentence A one slide summary of meningitis and encephalitis. Everyone knows meningitis. It's just fever, headache, neck stiffness, and photophobia. There's two clinical signs that some people might not know that might need to be aware of, and that is Koenig sign and Brudzinski sign. The Koenig sign is a little bit more well known, but essentially to do that, you flex the patient's hip and the knee, and then you straighten the leg. And if this causes neck stiffness in the patient, it indicates that there is significant meningeal irritation, which is indicative of meningitis. The one that is used more frequently in children and young patients is Brudzinski sign, which is where you flex the neck, and by flexing the neck, if it causes automatic flexion of the hips and the knees, as in the patient can't prevent that, it indicates once again significant meningeal irritation, with one possible cause for that being meningitis. And of course, meningitis has a lot of causes to it. One of them is viral, there's bacterial, there's fungal. The most common in the UK cause of meningitis is actually viral, but I'm going to show you how you can separate the causes based on the history and the lumbar puncture findings in the next slide. For encephalitis, I've said it's just meningitis plus behavioral change and seizures. The main cause of encephalitis is herpes simplex virus in the UK, and pretty much a lumbar puncture is essential. There are to delineate the true diagnosis. There are some contraindications to a lumbar puncture, but most cases in real life, unless there's an established space-occupying lesion and or features of raised intracranial pressure, you can carry on with a lumbar puncture. Nice and simple, the management. You just treat meningitis with high-strength antibiotics. In the UK, they use third-generation cephalosporins like ceftriaxone. This may vary from country to country, of course, so always check your local guidelines. And encephalitis is generally treated with antivirals, with the most commonly utilized being acyclovir. And this table shows a quick guide on how to interpret a lumbar puncture results and correlate it with the respective cause of meningitis. So as you can see, normally the lumbar puncture fluid is nice and clear, the protein level's okay, glucose is fine, it's similar to the body's level, and there's nothing seen on it. But if it's turbid and cloudy with a raised pressure, think bacterial. If it's clear, but there's raised lymphocytes in particular, rather than polymorphonucleocytes, that's going to be viral. And if the glucose is very, very, very low, and I mean much lower than you'd expect, even in a bacterial infection, think TB or some fungal infection. And those are the key points that I draw your attention to. But I can send you these slides if you'd like them after the session. And finally, we're on to our last case of the day, which is called Conor's Nan, or Conor's grandma. That is not my grandma, but my grandma did have this condition. So I felt a person to help you remember it by that way. The case history is as follows. The patient's name is Jean. It's Conor's gran, so you have to treat her right, okay? You have to be nice to her. She's a female. She's normally fit and well, but she presents to the emergency department with a 2-week history of headache. In terms of the pain, she rated as an 8 out of 10, with 1 being no pain and 10 being the worst pain possible. But she's also complaining of blurred vision, which isn't normal for her. She also said that she generally feels quite tired, feels weak, and she has jaw pain when she eats food, which she seems very strange. Everything's very strange for her, and she's quite tired. Another strange feature is that the pain gets worse in the mornings when she combs her hair when she's getting dressed. You've carried out an A/E assessment as the doctor, and it's mainly normal. And very luckily for you, a helpful senior doctor who knows what's going on has already taken some bloods from the patient and has said, I've sent them off for everything we need, don't worry. So the next question is, what is the most appropriate management step for Jean? So what should you do next? So it seems like there is a bit of a there's a bit of a debate as to what the answer is here. Okay, so it seems like people are relatively split. Only half of the people in attendance have got this one right. I'll tell you the answer, and then we'll go through it. The answer to this question is that you should start the patient on prednisolone, and that's 60 to 80 milligrams, which is also known as high dose. I'm going to spend a bit of time going through each option and why it's not the best choice. Firstly, option A, which is waiting for blood tests to come back before deciding on management. I understand why people have said this. However, in accordance with the history, the senior doctor has most likely taken the bloods, and what that means is we'll know before the patient's had any treatment if their ESR in particular is raised. That is indicative of giant cell arteritis, so we've already got the blood result coming to us. In the meantime, this is an emergency, so we can treat the patient straight away, especially as they have visual symptoms. So that's the rationale behind just treating them anyway. Is you already have the blood test ready to go. As far as urgent rheumatology referral goes, these patients are often under the management of a rheumatologist. However, this is an acute emergency situation because the patient has visual symptoms, and we need to be mindful of that. Booking an urgent MRI scan would be good, I guess, but it's not the definitive investigation for this condition, and that leaves us with starting prednisolone, which is the optimal solution. In patients with this condition, you start them on high-dose prednisolone. That is the standardized treatment. Low-dose prednisolone is used for polymyalgia rheumatica. This patient has some symptoms of polymyalgia rheumatica, but the main issue they have at the moment is they clearly have giant cell arteritis. So that's the condition that they have. It's very classical of it, and that is why we treat them with high-dose prednisolone. Straight off the bat, we don't bother about any other investigations. Someone's asked, because we're giving high doses of prednisolone, is there a chance of toxicity? And if so, how do we combat and prevent it? Well, in this slide, I'm going to go through how we can best counteract that, because it is going to be an issue. But firstly, what giant cell arteritis is. It is a large vessel vasculitis that commonly affects the temporal arteries on the temples. The most commonly affected is the superficial temporal, so it's just the one that goes up the side of the head there. And it happens in mainly elderly patients. So if any elderly patient over the age of 50 has a new onset headache with those symptoms, think giant cell arteritis. And the features mainly are headache, scalp tenderness, which was exhibited by the patients having difficulty combing her hair, jaw claudication, which is again specific for giant cell arteritis, and features of polymyalgia rheumatica, which are generally feeling weak and feeling tired. In terms of the optimal investigations, the senior, who was very kind in doing the blood test for us, has already probably went for it and got an ESR. ESR is a non-specific marker of inflammation and chronic illness, and for some reason it's raised in temporal arteritis or giant cell arteritis. So that's a mark you want to use, and it's usually over 50. The best way to diagnose giant cell arteritis officially, if you have time, is a temporal artery biopsy, but even then it's not fully sensitive. Now, the reason why we didn't do a biopsy in this patient was because she had blurred vision, and that means that she is actually at risk of the devastating sequelae of the condition. The big problem with giant cell arteritis is that it can lead to visual loss. So it's very important that if patients have these symptoms, you treat them quickly and very fast with the treatment, which is long-term high-dose steroids as soon as possible, which is high-dose prednisolone in the UK. Now, relating back to the question that was asked, if you are treating patients on high-dose steroids for a long time, you're definitely going to encounter side effects. And unfortunately, this is the only treatment available that works. So we need to be mindful of those and proactively aim to prevent them. And two things you can do is not necessarily to avoid toxicity, but to avoid potential long-term side effects, is you need to think about covering these patients by treating them concurrently with a proton pump inhibitor, such as omeprazole, which is for gastric ulcers because high-dose steroids can cause gastric irritation, and also bisphosphonates, which are designed to help with maintain bone health because steroids can have a deleterious effect on your bone health. So things like that, and make sure you cover for them as part of your treatment paradigm, is essential as well, because you want them to maintain their vision, of course, and you want them to be cured, but you also want to avoid giving them potentially devastating side effects that glucocorticoids can evoke. And that brings us to the end of the presentation today. I really hope that you've all found it useful. There's a link there to the feedback form, and I'd really appreciate it if you could just maybe get your phone at the moment, screenshot this page, or just take a picture of the QR code, and that will take you through to the feedback form. I'd really appreciate the feedback, and it helps us get better as a society and me as a speaker. And it's really good to have. I'll just answer a couple of questions because I think there's been a couple before I bid everyone farewell. Someone's asking, if someone presents with a history of symptoms but no visual loss, say they presented GP, so if someone doesn't have, it's a bit less urgent, a bit less acute. What I've seen really, what you would do if you're the GP in that situation and the patient is well clinically, but you still suspect it, then you can do a few things. So firstly, take a blood sample, a routine one, and send that off before starting any treatments. So that way, you've still got a baseline ESR to play with. After that, it's your call what you want to do. But generally speaking, patients get referred to rheumatology. They get started on steroids in the GP practice where they're at, and then they get referred for a biopsy later. So then you've already started the patient on steroids to make sure they're okay. They get to see a rheumatologist who can stop them if it's not giant cell arteritis, but you can also have the biopsy and also get the ESR back as well, and then use that to inform your decision a bit later.